on decision factors related to the use of unstable devices. My name is Tuala Chair, and our research advisor was Dr. Cindy Guria.
My name is Rachel Destiny.
And I'm Tamara Bates.
So types of unstable devices include wobble boards, balance boards, stability boards, and foam pads. So what is the current evidence that we know right now? And we know that unstable devices are used in the clinic for injury prevention and to challenge the neuromuscular and musculoskeletal systems in order to improve joint stability. We also know that they are used as adjunct therapeutic treatments for in treatment of impairments such as musculoskeletal pain, poor balance, and muscle weakness. And then we also know that they have a positive effect on the treatment of sprains and strains. And then you see the higher core activity as compared to stable devices. So what is unclear about the evidence? It is unclear as to what might influence a physical therapist to use an unstable device. Like what factors are they considering before making their decision to use a particular unstable device in the patient's plan of care. Which leads us to the purpose of our survey, and the purpose of this study is to identify factors that might influence a physical therapist's choice in selecting or implementing an unstable device in the plan of care for a patient. And then the second aim of our study is to determine if research study influences the choice of an unstable device used in patient populations. So our survey development, we had three general sections in our survey. We had demographics, types of unstable devices used in the clinics, and factors that influence PTs in using an unstable device. And then a pilot study was sent to an expert panel of 5 PTs, and then their suggestions were then used to modify our survey. And then our 22 question survey was then converted into Qualtrics tool. So our survey questions were divided into these categories, and then it was estimated that it was going to take 20 minutes for participants to complete our survey. So the participants were mostly licensed PT in the Ohio and Michigan area, with 80% coming from the Northwest region of Ohio. And then an email was sent to them, including an invitation to participate in our survey, an information consent form, and an electronic link to our survey. And then reminder emails were sent 1 week and then 2 weeks later. And then the inclusion criteria, we included all PTs in the Ohio and Michigan area. And then the exclusion criteria, we excluded any full-time professors or PTAs.
Okay, so 184 physical therapists were invited to complete our survey. Of the 184, we received 21 responses, which equates to an 11% response rate. 3 people were unable to complete all of the survey questions, which equates to an 85% completion rate. The vast majority of our clinicians have been practicing for 10 or more years, are ABTA members, see 10 or more patients per day, work in the outpatient setting, and work with orthopedic conditions. 76% of the clinicians are not board certified specialists. Okay, as for our results, we found that over half of the participants selected that they would utilize unstable surfaces to treat those patients with neurological-based conditions. The most common devices found in the clinics were unstable foam and unstable board devices. All of the participants indicated that they frequently utilize unstable devices as part of a treatment plan. And when asked if they would utilize 3 or more different devices in a single treatment session, 43% agreed, 43% disagreed, and the remaining 14% were indifferent. 71% of respondents indicated that they felt that certain unstable devices were more effective in achieving clinical outcomes compared to other unstable devices. Okay, the participants were asked to rank the factors that they would use to select an unstable device for a treatment session. The top 3 answers given were the patient's safety, the patient's current physical impairments, and the difficulty of the unstable device. 81% of participants felt that in order to improve a patient's balance, it is necessary to utilize an unstable device. And when asked to rank the factors that would affect their decision on progressing a patient when using an unstable device, The majority answered that they would utilize a variety of devices throughout the plan of care. The majority of participants indicated that evidence is the most important factor for the effectiveness in progressing an exercise dosage. And during their schooling, 71% agreed that they received information regarding the evidence of supporting the use of unstable devices. However, our results showed that only 48% felt that when choosing a particular device, their decision is based on the evidence of that device. 86% responded that they have not read a research article regarding unstable surfaces in the past year. And the top factors for ruling in and ruling out utilizing unstable devices were the patient's safety, the patient's impairments, availability of the device, and the PT being familiar with the device. Evidence was not a top-ranked option. Lastly, the participants were asked to rank the factors that would affect their decision to purchase a device for their clinic. The top 3 answers given were cost, easy setup of the device, and the device being easily transported around the clinic. Evidence and normative data were not among the top-ranked options.
Okay, so the main trend that we noticed as we were analyzing our data was that evidence is really important to clinicians in regards to how they're going to progress a patient's treatment plan and which device they're going to select to use. However, when asked if they've read an article within the past year, the majority said no. Luckily, they did receive education in the PT curriculum that supported the use of unstable devices. Another trend we noticed was that majority of participants believe certain unstable devices were more effective than others, which ties into evidence. And then another trend was that safety was considered an important factor when they were deciding which unstable device to choose. All of what we kind of saw correlated to an article that we did read, which pretty much shows that evidence is not the only thing clinicians are using to make their decisions off of. They're using a combination in their clinical reasoning. One limitation that we had was that we had an 11% response rate. We know that 50% response rate is considered adequate for online surveys, and that we do know that online surveys show a poor response rate if they post the ones, so the ones you get in the mail. There was also the potential for survey fatigue due to COVID and the fact that we had a lot of questions. We had a small sample size due to convenient sampling. The APTA does have a mailing address list of 100,000 members. However, it does not include email addresses. And it also has a pretty hefty cost of $239 for the first 1,000 names, and that increases as you include more names. There is also the potential for bias due to geographical size and region, potentially affected by the type of degree clinicians have, and also the fact that some people could have went to UT's DPT program. So for clinical implications, again, we know that clinicians felt that evidence is really important in their decision-making process. However, evidence is not the only thing they're using. They're also including patient safety and physical impairments. So for future research should be directed in trying to understand what barriers are blocking literature from reaching practicing clinicians, and also why is there a lack of evidence to support the use of unstable devices, more so like the normative values, and so that we can use that for evidence-based practice. So again, in conclusion, we know that clinicians identify evidence as an important or a critical factor in the decision-making process. However, patient safety, their current physical impairments, the difficulty of the unstable device are the top 3 factors in selecting an unstable device. As references, we want to thank Dr. Bullion for her guidance in our research survey, and thank you guys for listening. We open the floor to questions.
We did not have a specific question that addressed that. It would be a good addition in the future research, but we did not find any results that indicated that.
Well, what do you think accounts for the disconnect between the perception that evidence is important, but I don't look at it?
I think a survey that we looked at was looking at more balance assessments, and in those clinicians were looking more at like how a patient presents as, and also like looking into what they can use for objective parts of documentation, and and also like the perceived value of an outcome measure. I think that because of balance, assessments have like the gold standard, devices do not. As we were looking through, we couldn't find any information about that. So I think they learned that stuff in like their clinic, in school, and also from their coworkers, but they aren't able to like pinpoint this device helps with this kind of condition or so forth. They just know that a general device can help them. Does that make sense?
So why do you think they're not reading, what do you think it counts for not reading an article or looking at literature?
There wasn't really a lot of articles about it. Yeah, so I don't, and I think only one person was able to tell us the article, right?
Yeah, I think there's just a lack of research on unstable devices. I think we have a lot of research on how they're effective on like improving muscle activity, but comparing them to each other and trying to decide what to choose over each other is also a lack of in the evidence as well.
If you were to send out the survey again, how do you think you would try and increase the response rate?
A few ways to mitigate response rate is you can increase with incentives. You could shorten the amount of questions you have, which overall decreases the amount of time requirement to complete the survey. And then just overall, sending out more survey links, like if we would have used the APTA mailing list, or going through mail to increase the amount of surveys that we receive back would be a way to mitigate the response rate being so low.
And then you can also like print out copies of your survey and take to the clinic and say, like go to people's lunch breaks, say, oh, can you please complete our survey during this time, so we have more response that way.
I think in your survey you had a question where they identified the types of unstable devices that they had in their clinic, is that correct?
Mhm.
And do they just pretty much across the board, the people who responded, do they have the maybe less sophisticated, more common types like you had pictures of? Did they have any more high-tech equipment available?
Some of them had more high tech. I know at least one had some virtual reality available, and there was a few others that were more high tech.
A cable one. I think it depended on what facility they worked into. A lot of ours were like orthopedic outpatient type of things, and not more so like specifically neuro outpatient.
I wanna go back to the.
Okay.
So did you see any link or correlation between any of the demographic data that you collected and whether or not someone was likely to access the literature?
Same thing about the equipment. If they had more high-tech equipment, did they tend to access the literature?
That's a very great question.
Awesome, Dr. Patel. We did not see that, but I'm going to assume maybe.
Some of the things related to the type of degree that one has, and look at whether ETA members and their clinical specialist or certified. One would expect to see some.
Right.
Yes.
If there was linkage, a lot of them were APTA members, so they would likely be able to access that. A lot of our clinicians have been practicing for 10 more years, so that kind of infers that they have more bachelor's degrees. But we still did have a good mix of 0 to 9. So that also states that there's some doctoral and master's degrees in there as well.
Thank you.